broadcasting from two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 96. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Hi, Swapnil. Long time no see. How have you been?
I'm pretty good. Yeah, it has been a long time and it's good to be back. And there are a few interesting trials which have been recently presented at Critical Care Reviews meeting and published in New England Journal of Medicine. So it's good to be back and do this journal club today. And the trial that we have chosen today is called as LOVIT Trial. And this trial was recently published in New England Journal of Medicine, which basically evaluates the effect of intravenous high-dose vitamin C, whether it reduces the risk of death or persistent organ dysfunction at 28 days in adults with sepsis who were receiving vasopressor therapy in ICU. Now, this trial is a landmark trial because this is probably the largest trial on this topic. And this trial has given us a very important results that will hopefully put the full stop to this debate on use of vitamin C in patients with septic shock. Now, just a bit of context to this whole topic. We know that vitamin C, initially postulated by Paul Merrick, that it might have a significant antioxidant effects and might mitigate the tissue injury induced by oxidative stress during septic shock. And also we know the fact that vitamin C cannot be synthesized by humans, and the levels of vitamin C are extremely low in many critically ill patients, which has probably increased the possibility that if we supplement vitamin C via intravenous route, that might augment our immunity and also decreases the risk of mortality. Now, the issue with vitamin C debate is initially the protocol, which is popularly known as Merrick protocol, which administered vitamin C along with hydrocortisone and thiamine. And that has shown to either decrease the need of vasopressors quickly or decrease the overall mortality in some of the trials and very early small trials. But subsequent trials like vitamins trial, which was conducted, did not show any benefit of this cocktail therapy in patients with septic shock. So the debate was really, is there a benefit of high-dose vitamin C, or is it the vitamin C when it's combined with hydrocortisone, that's where you get the benefit of this cocktail therapy. And then another trial which was published in ARDS, Citrus ALI, which again showed a decreased mortality in patients with high-dose vitamin C. So there has been multiple trials on this topic, which has given us probably a bit more mixed signals. There was no single large randomized controlled trial to evaluate the efficacy of isolated high-dose vitamin C on patients with septic shock. Adrenal trial obviously studied the effect of steroids in patients with septic shock. So this is good. This trial came out now, which basically studied the effect of only high-dose vitamin C on patients with septic shock. So Dr. Checo, can you please walk us through this landmark randomized controlled trial on this topic, please?
Yes, Swapnil. So this study was conducted in 35 medical surgical ICUs across 3 countries, Canada, France, and New Zealand. They included patients with infection who were diagnosed to have infection, who were on vasopressors and were admitted to the ICU for not longer than 24 hours. They excluded patients who had contraindications for vitamin C, those who received open-label vitamin C, patients who are expected to die, or those who are expected to undergo withdrawal of life support measures within 48 hours. On the intervention arm, they used vitamin C in a high dose compared to what has been used previously. The dose they used was 50 milligrams per kilogram in 50 mils, 5% dextrose or normal saline, administered 6 hourly over a period of 30 to 60 minutes. So this works out to, for a 70 kilogram person, to work out to 3.5 grams 6 hourly. So that's almost twice as much as Paul Merrick used in his original trial and many other trials after that as well. The treatment continued for a period of 96 hours for a maximum of 16 doses. provided the patients remained in the ICU during this period of time. And in the control group, they administered a matching placebo. In both the groups, thiamine and glucocorticoid could be administered based on the clinician judgment. They followed up patients by telephone interview at 6 months. For calculation of sample size, it was based on a 50% risk of death or organ dysfunction in the control group. So it was based on a composite outcome of death or organ dysfunction, assuming it to be 50% in the control group. And for a 80% power, for a 10 percentage point difference in the primary outcome, each group had to have 385 patients with a two-sided type 1 error of 0.05. So they started off like that, but as the COVID pandemic set in, they increased the sample size so as to include patients with COVID-19 as well. So they wanted to preserve the sample size even without COVID-19 patients. So they increased the sample size appropriately. So they screened 2,234 patients for eligibility, 872 patients underwent randomization, 435 in the vitamin C group and 437 in the placebo group. 429 patients had complete follow-up by day 28 in the vitamin C group, and 434 patients had complete follow-up at day 28 in the placebo group. If you look at the baseline characteristics of these patients, their severity of score by Apache 2 score and SOFA scores was similar. The source of infection was pulmonary. In the vitamin C group, it was 33.8 versus 36.7 in the placebo group. Similar numbers for gastrointestinal or intra-abdominal infection. Septic shock was present in 59.6% of patients in the vitamin C group compared to 56.1% of patients in the placebo group. So they were pretty sick in terms of severity. 68.5% of patients in the vitamin C group were mechanically ventilated compared to 65.4% of patients in the placebo group. Similar numbers of patients who underwent renal replacement therapy or vasopressor infusion. Vasopressor infusion was nearly 100% in both the groups. The median stay in ICU was 6 days, with an interquartile range of 3 to 12 days in the ICU and 16 days interquartile range 8 to 32 in the hospital. So what were the outcomes they looked at? The primary outcome, as I mentioned, was the composite of death or persistent organ dysfunction at 28 days. Persistent organ dysfunction was included vasopressor use, invasive mechanical ventilation, or renal replacement therapy. So any of these three would constitute persistent organ dysfunction. So the composite primary outcome of death or persistent organ dysfunction occurred in 191 of 429 patients in the vitamin C arm, compared to 167 of 434 in the placebo arm. So this actually worked out to 44.5% of patients in the vitamin C arm compared to 38.5 in the placebo arm. And this difference was in fact statistically significant in favor of the control group, with a risk ratio of 1.21, 95% confidence interval 1.04 to 1.4, and P of 0.01. So the composite primary outcome of death or persistent organ dysfunction was significantly higher among patients who received vitamin C compared to the control group. And there was no difference after applying the best or worst case scenario for one patient with unknown status of primary outcome. They also performed an adjusted analysis after adjusting for pre-specified baseline characteristics. And after adjustment, again, the risk ratio stood against the use of vitamin C. 1.15 was the risk ratio, 95% confidence interval, 0.9 to 1.47. So this data clearly showed that the composite primary outcome of death or persistent organ dysfunction was significantly higher with the use of vitamin C compared to placebo. The secondary outcomes included 28-day mortality, which was 35.4% with vitamin C compared to 31.6% with placebo. Again, higher, but the difference was not statistically significant for the 28-day mortality. They looked at the median number of days without organ dysfunction at day 28, assuming that vitamin C may have some role to play in ameliorating organ dysfunction. Here again, the median number of days without organ dysfunction was higher with the placebo, although again not statistically significant. 17 days without organ dysfunction with vitamin C compared to 19.5 days without organ dysfunction in the control group. They also looked at the SOFA scores at specific time intervals between day 1 to day 28, which was no different between the groups statistically. They looked at biomarkers, 6-month survival, and the health-related quality of life, none of which were different between the two groups. They also looked at safety outcomes. There was no difference between groups in terms of pre-specified safety outcomes. There were 4 adverse events in the vitamin C group and 1 in the placebo group. In one patient in the vitamin C group, there was a serious adverse event of anaphylaxis, and another patient had a severe episode of hypoglycemia, which may or may not have been because of vitamin C, but they had to take precautions to do blood sugars more frequently, given this report of hypoglycemia in one of the patients. So to sum it up, the composite primary outcome of death or persistent organ dysfunction was significantly higher with vitamin C on adjusted analysis after adjusting for specified baseline characteristics. Although the mortality was higher, the difference was not statistically significant. And none of the secondary outcomes, including 28-day mortality, SOFA scores, 6-month survival, health-related quality of life, none of these were statistically significant.
Thanks, Dr. Chakor. So I guess this is definitely a largest and pretty landmark trial on this topic so far on the subject of vitamin C in patients with septic shock. I think the strengths of this trial is it's a multi-center, placebo-controlled, randomized controlled trial conducted across 3 different continents, we can say, and 3 countries where the intensive care is really well protocolized and well practiced. So I guess it's a very robust trial design, and it's a very good follow-up, and also 100% compliance with the administration of the intervention, but also 100% compliance with the data collection. Now, as you mentioned, at the baseline, there was no statistically significant difference between the 2 groups. And most of the patients that what we normally see in our intensive care unit. So it's a very pragmatic trial design. Most of the patients come with source of sepsis from the medical wards. Some patients do develop sepsis after emergency or elective surgery. Apache score between the 2 groups was again quite significantly higher. So obviously they included sicker cohort of patients. And as expected, the pulmonary and intra-abdominal sepsis was the dominating source of sepsis amongst these patients, because there was some suggestion about whether vitamin C is better in pulmonary sepsis compared to non-pulmonary sepsis. So again, this trial gives us a better picture about the actual effect of intervention, that is vitamin C in patients with sepsis. Interestingly, they did measure the baseline level of vitamin C in this trial, which was also quite similar at baseline between the 2 groups. So again, nobody can argue that these patients had a different vitamin C level at the baseline, and that's why one group had more harm than the other. And also other interventions which were used with these groups, such as glucocorticoid or vasopressor infusions, there was no, again, difference. So because most of the countries have now do practice steroids in patients with septic shock when there's a escalating doses of vasopressors are used in these patients. So I guess I'm very happy that there was no difference at the baseline between the 2 groups. So I guess the overall trial is quite robust, well-designed, and really well-conducted trial. Now, the key limitations of this trial, and to be honest, the most disappointing factor about this trial is the primary outcome, which is a composite outcome. And I understand sometimes it's hard to do a trial just looking at a 90-day or 28-day mortality, because then the sample size increases. But when you obviously trying to evaluate the composite outcomes, that's obviously automatically trial becomes more underpowered. And also they went for 80% power rather than 90% power. On the one side, they assumed the the risk of primary outcome when they calculated the sample size was supposed to be 50%, and they aimed for 10% reduction in each of these parameters to calculate the sample size, which was quite ambitious to start with. Now, what they got in the intervention group in terms of mortality plus persistent organ dysfunction was around 44%. So it was close to what they predicted. But the 10% reduction was quite ambitious, I guess, to calculate the sample size. Having said that, this is obviously the trial which actually showed that if we just use intravenous vitamin C in patients with septic shock, then it will lead to harm. So obviously, it has given us a very clear answer on this topic. And I guess another limitation that author mentioned, which I don't think it affected the trial results that much, where they said 9 patients underwent randomization but did not contribute data to the primary outcome. And I guess even probably they could have been randomized to either group. So it probably doesn't matter that much because the event rate was so high in the intervention group. So I guess that shouldn't have made a difference. And also, obviously, this trial, as I mentioned before, it was conducted in a very well protocolized and well-developed countries with a very meticulous intensive care practices are followed. So I guess the question is whether we can extrapolate these results to lower or middle income countries. And that's the unknown part of this whole debate. So clearly, this trial has given us quite interesting results, which will be obviously won't be changing our practices. But at the end of the day, it has given us a clear answer on this topic. What's your thoughts?
Yes, Swapnil, I totally agree with you. This study is, in fact, a very large study, the largest study that has addressed the question of vitamin C in patients with sepsis. And it has given a clear-cut answer in that, if anything, the use of high-dose vitamin C in the dose that they use, which is 50 milligrams per kilogram 6 hourly, could actually be harmful. So there seems to be a very clear-cut answer in this fairly robust trial. And I would go by that. Not that we use vitamin C to a large extent in patients with sepsis anyway, but this adds to the already available evidence with several randomized controlled trials published in the recent past, including the vitamins study, as well as the citrus alley study. There have been a few other studies as well. And in fact, there was a study from South Korea recently, the Vit C trial, which again did not show any difference in the median ventilator and vasopressor-free days with vitamin C compared to placebo. So this adds to that body of knowledge, which suggests that unlike the Merrick study, which was a retrospective study, before and after study, which came up with this possibility that the cocktail of thiamine, hydrocortisone, and vitamin C in a dose of 1.5 grams 6 hourly could reduce mortality. None of the other studies of sufficient power have actually shown benefit with the use of vitamin C. Now, you might ask the question that would a higher dose have resulted in possible harm, or would a 1.5 gram 6 hourly dose may be a more optimal dose? The answer to that question is not very clear, but definitely high dose vitamin C in patients with sepsis appears to be harmful. And I don't think we would use that in our practice either.
Yeah, I guess that's fair to say that now we got more evidence. And I guess when you look at some of the previous trials, then you start putting the evidence together. Now, there is a systematic review which was published in NEJM Evidence of combining all the trials on this topic and then trying to see what's the final answer of vitamin C in patients with septic shock. And obviously, to surprise, this meta-analysis does say that when you put all the trials in one basket, this meta-analysis does suggest that there is a benefit of using vitamin C in patients with sepsis. Having said that, most of the trials included in this meta-analysis are quite questionable with the quality of evidence. And they're a very small center. Most of them are single center randomized controlled trial. And that's why the overall meta-analysis can't be really interpreted properly. Having said that, when they looked at some of the well-conducted selective randomized controlled trial, then obviously the vitamin C does not kind of favor the reduction in mortality. So the meta-analysis changes when they included only selected trials. One can also argue about the overall, the dose of, as you mentioned, the vitamin C, but the 50 milligram per kilogram has been quite standardized dose, and even in Marek protocol and subsequent all the trials. So I guess even at that dose, if the vitamin C is showing probably harm, I guess there's no point in using high dose vitamin C. So I guess that shouldn't be the major factor. Now, one of the criticism of vitamins trial, which was published by Fuji and Paul Young, was that the vitamin C was administered a bit late. And one of the argument that probably the effect of vitamin C will be more if it's administered within first 6 hours or 4 hours of presentation. And this trial actually did address that point, because the vitamin C was administered within first 4 hours and then obviously continued for 96 hours of period. Citrix ALI was the study in patients with ARDS where they administered vitamin C within 6 hours. And that trial showed the benefit. Now, the problem with the Citrix ALI, though, was the number of patients included in that trial were quite small. And that's why it's generalizing that trial findings and to change the practices obviously probably won't make sense. So I guess this trial overall, although I was not very happy with the primary composite outcome, has obviously given us a very clear signal that even if you administered a vitamin C intravenously within first 4 to 6 hours and then continue for first 4 days in patients with septic shock, it actually causes more harm rather than giving us the benefit. So obviously, as I mentioned before, it won't change my practices, but I guess it will probably put a full stop to this topic, at least in patients who are coming with us only septic shock. And I think that's a really good outcome of this trial, I guess.
Yes, I agree with you, Swapnil. The only question that would remain, I suppose, is whether a combination of all three, the cocktail that Marek proposed, would that make a difference? I doubt very much. We have the vitamins trial, which addressed that question specifically, and it came up with negative answers. So I don't think we need to explore much further on this topic of vitamin C. We have substantial evidence, I think, to suggest that high-dose vitamin C in patients with sepsis and septic shock, not only would it not help, it might possibly be harmful as well. As you mentioned, the meta-analysis included some 40-plus randomized controlled trials, the meta-analysis that was published in NEJM Evidence. And many of these studies would have been of low quality. In fact, when they excluded studies of low quality, they could not show any difference, could not show any advantage with vitamin C. So I suppose, as you mentioned, there is hardly any evidence to support the use of vitamin C in such mega doses in patients with sepsis.
Yeah, and I guess you're right. Once you combine the vitamins trial with this trial, it makes now sense that in each trial, obviously, especially vitamins, probably the benefit was due to the hydrocortisone in each group rather than the use of vitamin C in patients with septic shock. So, and clearly, when you just use isolated vitamin C in high dose in patients with septic shock, it probably might be more harmful than actually beneficial. So obviously, combining these two trial results plus combining the adrenal trial results, I guess now we have enough information around why we shouldn't use intravenous vitamin C in patients with septic shock. Thanks, Dr. Chacko, for your time. And I think it's a good trial to discuss to start off with. So we'll be back in week's time with another topic. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. We'll meet next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.